In this section, we cover carbohydrate metabolism and diabetes. So the endocrine pancreas is a structure that is involved with the generation of the key hormones that's involved in carbohydrate regulation. And as shown in this slide is a section through the pancreas with an island of cells called the islets of Langerhans, which is surrounded by a large amount of acinar tissue, which is the exocrine pancreas. By looking specifically inside the islets of Langerhans, there are 4 specific cell types: the alpha cells, beta cells, delta cells, and the PP cells. The alpha cells are responsible for the production of glucagon, which is about 10% of the output from the islets. The beta cells make up the bulk of the islets, about 70 to 80% of them, and the main product of the beta cells is, of course, insulin. The delta cell forms a much smaller portion, and the output of the delta cell is somatostatin. And then finally, even smaller proportion of the cells are called PP cells, and they produce pancreatic polypeptide. So clearly, the bulk of the endocrine pancreas is involved in the secretion of insulin and glucagon, and these will be the 2 hormones that we will be focusing on in this section. So in terms of insulin, it's important to understand how insulin gets processed. Insulin is made as a pre-pro hormone. So there is pre-pro insulin, which gets cleaved and processed to proinsulin, and proinsulin then ultimately gets cleaved to the mature insulin. And the main event that happens here is the cleavage of the C peptide or the C chain in the proinsulin to the insulin step. And this has pathological and pathophysiological consequence because it can allow us to distinguish between hypoglycemia that is caused by an endogenous cause or by an exogenous cause. So again, if you're making insulin endogenously, there is plenty of C-peptide that is made with the insulin, whereas insulin that is given exogenously already has the C-peptide removed, and so there is no C-peptide in exogenous insulin. So if someone comes in with hypoglycemia and you want to know whether it's because of an insulinoma or because of fictitious use of insulin, all you have to do is measure the C-peptide. In insulinoma, C-peptide levels will be very high, and in fictitious insulin use, C-peptide will be very low. This question is asking, during the conversion of proinsulin to insulin, bonds between which of the following amino acid residues keep the 2 chains of the insulin molecule together? The correct answer for this is cysteine. So it is the cysteine residues which actually hold the 2 chains together. So the A and the B chains, which is in the mature insulin molecule, are held together by disulfide bridges. And these disulfide bridges are anchored onto these chains by cysteine residues. In terms of how insulin is actually secreted, is shown here schematically in this diagram. So insulin is not released randomly. Insulin is released only in response to glucose. And it's a very nicely coupled system. So if the glucose levels are high in the blood, insulin is released, and insulin lowers the glucose in the blood. So it's a very nice feedback system within the beta cell itself. And shown and depicted here is a schematic of the beta cell, and is responding to exogenous glucose. So when glucose levels go up in the blood, glucose is taken up into the cell by a glucose transporter. Glucose then is oxidized inside the cell by the process of glycolysis, which then results in the generation of ATP. Generation of ATP raises the ATP to ADP ratio, which then closes the ATP-sensitive potassium channel. And the closure of the potassium channel then raises the intracellular potassium concentration, which then ultimately depolarizes the voltage-gated calcium channel to open, and then calcium comes in inside the cell, degranulates the insulin granules, and then insulin is subsequently released. The release of the insulin then allows for the glucose to be decreased, as we'll see in the subsequent slide. So again, the points are glucose binds to a glucose transporter such as GLUT2. The oxidation of glucose results in a generation of ATP. ATP then closes the potassium channels, leads to depolarization. When depolarization opens the calcium channels to release the insulin from the granules. So it's a very nicely coupled process. To try to put this in some clinical context is a question that tries to highlight this. So this is a 52-year-old man who's recently diagnosed with type 2. He comes to the doctor for follow-up. Physical exam is fine. laboratory study shows an increase in A1C, which shows that he's not well controlled, and the treatment with sulfonylurea is started. So which of the following is most likely to occur? So basically this question is asking what is the mechanism of action of sulfonylurea. So if you look back on the previous slide, sulfonylureas work again at the ATP sensitive potassium channels, and they work by closing that channel. So the closure of that channel results in the secretion of insulin, and so that is how sulfonylureas work. So they close the potassium ATPase channel and thereby increase secretion of insulin from the pancreas, which is answer number G. So how is glucose exactly lowered? So we said that insulin is released, and what does insulin do to lower the glucose? So there is the yin and yang effect in the body that maintains blood glucose levels in a very optimal range. So the insulin effects are mostly anabolic. So insulin lowers blood glucose by taking up the glucose into the cells. So muscle and fat are the two most common sites where the glucose is taken up. It also converts glucose into glycogen in the liver. It also prevents the breakdown of glycogen, and it finally prevents gluconeogenesis. So a combination of both the uptake as well as increasing in glycogen synthesis and decreasing gluconeogenesis, all of it results in maintaining blood glucose levels in a normal range. But what happens if your glucose levels fall really low? Then there is a series of events that happen by the action of what we call counter-regulatory hormones. And the main 4 counter-regulatory hormones for glucose lowering are glucagon, catecholamines, glucocorticoids, and growth hormone. And we've already covered all of these hormones in the previous sections. So the combinatorial action of all of these hormones ultimately raise the blood glucose level back to homeostatic levels so that you don't really drop your blood glucose levels too low. So glucagon is a primary defense against hypoglycemia, and it does that by increasing glycogen breakdown and increasing gluconeogenesis. Catecholamines, glucocorticoids, and growth hormone, all of them work by decreasing glucose uptake and therefore raising blood glucose levels. So as you can see, there is the yin and yang effect of glucose homeostasis, which ultimately achieves normal blood glucose levels. Let's look in a little bit more detail about how the secreted insulin in response to glucose brings the glucose levels lower back in the blood. So insulin is released from the pancreas, gets into the bloodstream, and works on the target cell. Let's say it's in the muscle or the fat. There are insulin receptors that are present in each of these cell types. Insulin receptors, if you recall, are again tyrosine kinase receptors. When insulin binds to the insulin receptor, the receptor dimerizes, tyrosine kinase activity is engaged, which results in the signal transduction cascade downstream. And one of the most important signal transduction cascades is the generation of glucose transporters. So GLUT2, GLUT4, any of these GLUTs are basically glucose transporters that are actually synthesized in response to insulin. And it's not only synthesized but also translocated from the cytoplasm to the cell membrane. So these glucose transporters sit on the cell membrane and they suck up all of that extra glucose and bring it inside the cell. So that's how the blood glucose is lowered by the action of insulin. And this happens in muscle or in fat. Here is another view of how that specifically happens in more detail. So when insulin goes to the target cell, such as, for example, the liver, what it does in the liver is that it decreases gluconeogenesis, it decreases the breakdown of glycogen, in fact enhances the formation of glycogen, so increases glycogenogenesis, and it increases glycolysis. In the fat cell, it actually causes the glucose to be taken up and triglycerides to be formed. And muscle, the same thing. It increases glucose to be taken up by the action of GLUT4, and it also increases glycolysis. In terms of the fat metabolism, again, it's a classic anabolic hormone, so again, it helps build fat. So it increases lipogenesis in the liver, and in the fat, same thing. It increases synthesis of triglycerides, increases fatty acid synthesis, it decreases the breakdown of fatty acids. And then finally, in terms of protein metabolism, it helps build protein as opposed to break down protein, especially in muscle. So the combination of the various actions in various cell types results ultimately in maintenance of blood glucose in the homeostatic range. As I said, the counter-regulatory hormone is glucagon. Glucagon, unlike insulin, does exactly the opposite. It works by activating the G protein coupled receptor, the GS subunit, to activate CAMP. So very different mechanism of action than insulin. Again, remember, insulin binds to insulin receptor with tyrosine kinase activity, whereas glucagon binds to a G protein coupled receptor with GS subunit activity, which increases CAMP, when ultimately results in the basically increasing glycogenolysis, which is a breakdown of glycogen, increasing gluconeogenesis, which is the formation of glucose, increases lipolysis, which is the breakdown of fat, increases ketone body generation, and finally works by counter-regulating the actions of insulin, as we talked about. So the net result of glucagon's action is, in fact, to raise blood glucose. Here are the pathophysiological consequences of dysregulation of carbohydrate metabolism. The most common manifestation is diabetes. There are two major forms of diabetes, type 1 and type 2. Type 1 is usually associated with a primary process that involves beta cell destruction. So this is where the beta cells, which is the source of the insulin itself, is destroyed. And most commonly it is immune mediated, or it could be idiopathic. It affects usually non-obese younger patients. So usually these are younger patients, usually in their 20s, in their teens. And there's a genetic component and association with a HLA link. In contrast, the pathogenesis for type 2 diabetes is not the destruction of the beta cell. The beta cells are actually overactive. And in this case, the problem is insulin resistance, meaning that the end organs like muscle, fat, liver are resistant to the actions of insulin. And as a result of it, the beta cell, at least initially, is overworking, is working really harder and raises the insulin levels. But raising insulin levels is not really helping as much because the end organs, which are muscle, fat, and so on, are not really able to respond to that insulin. So insulin resistance is a critical pathogenic feature of type 2 diabetes, and this is, in fact, the more common type of diabetes that we see, and in fact has a much stronger genetic component, about 60 to 90% concordance in twins. Acute complications are variable dependent on the pathophysiology. So in type 1 diabetes, the most common acute complication is DKA, and in type 2, it's less likely to be DKA, but in really severe cases, it can be something called non-ketotic hyperosmolar coma. But the end result of diabetes, whether it's type 1 or type 2, is ultimately the same as highlighted here, which results in eye disease, kidney disease, heart disease, and of course neurological disease. So the end result is the same, and hence the treatments are all geared towards reducing these complications. Besides type 1 and type 2, there are other types of diabetes called gestational diabetes. There's also diabetes that can be resulting from pancreatic damage, such as that happens with cystic fibrosis, or diabetes can be caused by a drug effect, such as prolonged exposure to glucocorticoids, or with something even malnutrition called tropical diabetes. These are all much rarer, and the most common ones that you will see and encounter are type 1 and type 2 diabetes. Here's a question that sort of tries to address the complications of diabetes, especially type 1. So this is a 12-year-old boy. He's brought to the emergency department because of vomiting and rapid breathing. Over the past 2 weeks, he's been drinking lots of fluids and urinating excessively. He's lost weight. He is thin, afebrile, drowsy. Respirations are deep and rapid, and there's a fruity odor on his breath. The laboratory studies show that he's pretty acidotic with a pH of 7. Glucose is high, and his BUN and creatinine indicate likely pre-renal failure. So which of the following is most likely to be increased in this patient's blood? So clearly, I think it's not that hard to make the diagnosis. He has DKA. All these signs and symptoms are indicative of that. And in fact, this fruity odor indicates that he probably has a lot of ketone bodies. In fact, that's likely acetone that's being produced. And his respirations are deep and rapid to try to blow off this excess acid, which is a clear compensation for his metabolic high anion gap metabolic acidosis. And the resulting sort of reason for all of this is the accumulation of beta-hydroxybutyrate, which is answer C, in his blood, that's driving this process. So this concludes the section on carbohydrate metabolism and diabetes. The important take-home points here are that insulin is released in response to glucose, and insulin lowers blood glucose by the action of activating glucose transporters to the cell membrane to suck up the glucose from the bloodstream, and counter-regulatory hormones like glucagon, growth hormone, catecholamines, etc. can try to counteract the effects of insulin to raise blood glucose back again so that homeostatic levels of glucose can be maintained. Pathophysiological consequences are certainly diabetes, both type 1 and type 2. Type 1 is mostly a beta cell destruction. Type 2 is mostly driven by insulin resistance. In the next section, we will cover the regulation of calcium metabolism and its pathophysiological consequences on bone. The important take-home points here